Good afternoon. It takes us a little while to get here from Taunton. Sorry, we're down in the southwest. I kind of feel like we've got a bit of a nature theme going on. We started with flowers from Leeds and we had some sharks from Sweden. And what we're hoping to do today is talk to you about our oaks that are in Taunton. That's Somerset in the southwest. So this is the story of our little acorn. And our acorn really started with an idea about 3 years ago now, just during one diabetes paediatric clinic. We were looking at a child's journey, and that child had type 1 diabetes and celiac disease. We wanted to see how we could improve a system that was seemingly inflexible for that child, a system that inadvertently imposed our expectations on that child and family to attend multiple specialist clinics simply because that child had multiple long-term conditions. The idea grew, germinated, and with quite small changes to our clinic arrangements, we have created what we feel is an oak tree. And we now have triannual joint multidisciplinary clinics for children with type 1 diabetes and celiac disease. And what we're proud to do today is to demonstrate that initiative to you.
Okay, so just as some background, you'll all be aware of the rising prevalence of type 1 diabetes. The same goes for celiac disease. The current estimated prevalence of celiac disease in the UK population is 1%, which is pretty substantial. Unfortunately, around 90% of those remain undiagnosed, and I think that probably reflects a change in presentation. So increasing numbers of celiac patients are presenting with few or no symptoms at all, as opposed to the classical presentation of celiac disease that we all recognise: children with pallor, lethargy, malaise, diarrhea, abdominal distension, and buttock wasting. The prevalence of celiac disease in type 1 diabetes is estimated to be around 6%. So again, a not insubstantial population. They share significant genetic overlap. The major genetic factor in the development of both diseases is centered around the major histocompatibility complex. So 90% of patients with celiac disease are HLA-DQ2 positive, with around 10% being DQ8 and perhaps other non-HLA genes. In diabetes, DQ8 predominates, with about 25% being DQ2. So this has been incorporated into clinical practice with the introduction of the British Paediatric Gastro Guidelines in 2013. So this allows us to avoid the need for a small bowel biopsy under general anaesthetic in a very specific subgroup of patients. So those patients who are symptomatic and they have very high tissue transglutaminase antibody levels, which are greater than 10 times the upper limit of normal. So that's clearly of benefit to that group of patients. The guidelines also suggest that it would be good practice for there to be subspecialist or specialist input at the diagnostic point, but also that with yearly review and ongoing follow-up, that care be centred and really carried out by one specific individual who has specific experience in managing children with celiac disease. So the benefits of gluten-free diet are pretty self-evident to those that are symptomatic, but there are a number of other benefits as well. Resolution of micronutrient deficiencies, better growth, reversed bone demineralization. There are some interesting benefits in terms of psychological well-being, reduced numbers with depression and mood disorders, delayed puberty, subfertility, and more importantly, long-term, reductions in risks of intestinal malignancy. The implications for celiac disease in those with type 1 diabetes is perhaps a little less clear. There is evidence that those patients adhere less well to their gluten-free diet. And I'm sure that's because, the additional benefit of the additional burden of the dietary changes is not insubstantial. there is conflicting evidence about benefits for glycemic control, and there are some papers in adult patients suggesting that there might be increased risks of retinopathy and end-stage renal disease, particularly if celiac disease is a very long-standing diagnosis over 10 years or more. And there's also suggestion that there may be increased comorbidity, as many as 25% in one series having a third autoimmune condition, mainly thyroiditis. So how did our idea arise? Well, we were all aware that our local cohorts were rising for both conditions. And certainly, with regard to celiac disease, there was a degree of variation in clinical care, particularly around diagnosis and subsequent follow-up. We'd also been involved in managing 2 or 3 families who really struggled, where they had both diagnoses right from the outset, and that caused them significant difficulties. And we had well-established, but at that point, quite separate services. So we set ourselves some objectives. We felt that it was really important that our service should be centred around the needs of our patients and their families, that we would try to optimise and standardise the service that we were delivering, and really to try and improve access and convenience for patients and families who were already attending pretty frequently. And then, again, that specific group of patients who really struggled with dual diagnosis from the outset.
So how did we develop this joint clinic? What I'm about to describe is the initial pilot that was 3 years ago. Clearly, we needed to identify our cohort, and that was easy for us. We knew our families. We were keen for the number of people in the consultation to be kept to a minimum, and as Isabel alluded to earlier in her speech, we wanted to make sure that the clinics weren't overwhelming for young people, and they were still personable and approachable. So we had our key professionals, our diabetologist, we had our paediatric gastroenterologist, a dietitian who had experience in both conditions, and clearly our PDSN. We obviously had access to psychology, as we would with our other clinics should we need it. The booking patterns for the clinics, initially the clinics were biannual, and that allowed each family to be seen once in that joint clinic alongside their routine diabetes clinics. The clinic appointment started as a 40-minute appointment, and we've actually maintained it as 40 minutes. In practice, we've adjusted the clinic quite a lot over the last few years. And the way that we're running it now really is to start the consultation with celiac being the primary focus for the consultation and the family, unless clearly they've got any burning issues to talk about first of all. And while that part of the consultation is going on, we do some diabetes data collection and some interpretation. And interestingly, the location of the clinic in terms of where people sit has migrated. And what we found is we're actually putting the family and the patient in the centre of the room, and our team members are rotating around and we're coming in and out, which wasn't intentional at the beginning. So here are the numbers. These numbers are from the pilot clinics over the first 2 years. All of our families preferred being in the joint clinic. Nobody wanted to be seen separately in the celiac or gastroenterology clinics. About 2/3 of our families found that the professionals was just about right for them, and it was from the young people who felt that on occasion there were too many people, and for those individuals we recognised that straight away, and we offered them separate or independent consultations, either parallel to that clinic or as a separate entity. Interestingly, we haven't got any families that want to be seen purely in a gastro clinic now. Majority of families were happy to discuss both their conditions in front of both the teams. They were very open about that, and they realised how the impact of one diagnosis clearly interlinked with the other and vice versa. Majority of families found they had enough time to discuss both their conditions within that 40 minutes, and again were offered extended time should they need so. This qualitative data is really the data that's kept our clinics going. These are free text comments from parents and young people alike. Essentially, they want to keep these clinics going. They found significantly less impact on their work commitments. There's significant less impact upon schooling and education for the young children. And there's a big reduction in travel costs and the associating parking costs that necessitate coming to hospital. And the overwhelming feeling was that families wanted these clinics promoted, both locally to keep them going and extended to other units.
Thank you. So I'm going to talk a little bit about what it's like at the moment, so what we're actually doing and what our plans are for the future. So basically, the clinic format now is well established. So when a patient with type 1 diabetes is diagnosed with celiac disease, we can tell them about the joint clinic from the very beginning. So they're actually aware. And in fact, a lot of families are actually asking when their next joint clinic appointment is. So it's good that that's become quite bedded in. It's shared between 2 dietitians. So I hope that's been quite good over the time, because it's meant there's always been able to be somebody available. How the clinics are impacting on us generally, we've put the patient and family at the top, but actually the changes that we've made and the way the clinic runs has positive impacts on actually all of us. Sometimes just the patient and family, sometimes just the team, but in general a lot of these things actually overlap. We were inspired at the beginning by the family, so we listened to what they said, so we've tried very much to keep that at the centre of everything that we do. There are quite a lot of qualitative measures that we've had, so I'll go through just a few of those. So we've talked about eliminating clinical care variability and inequality, and in fact our families have said that they're actually getting the same information. We're working quite hard as a team generally about the consistency of our message, and in fact I think all team members individually or between us have found that we've learned from things that people have said in clinic. And so it's helping us actually say the same things to families and keep that message consistent. And it also increases the confidence of staff who didn't know so much about one of the other conditions to actually be able to help families much more. Understandably, they'd much rather come 4 times a year than 5. And even though there are quite a lot of people in the clinic at the one time, in general, people are happy with that. And as was mentioned, we've been tried to be quite alert to where families aren't happy with that, and we've encouraged them to let us know. So if we do need to split clinics into smaller entities, we can do that. Certainly, reductions in time and cost of parental travel, as has been mentioned, and also meaning they're missing less school or time from family work, which is often an issue for families. Okay. The Trust are quite happy that we're managing to amalgamate blood tests and reducing lab costs, and if where we can, we try and combine bloods with their annual bloods so that actually it's only one time that we're actually asking for those bloods. One of the key things that we've found is that because we actually have a gastroenterologist on the spot with us, we've got much more streamlined decision making. In the past, we'd often have to say, well, we'll have to go away and ask the gastroenterologist that, or you'll have to wait for your celiac appointment. And so it's actually, we've been able to get on the spot decisions or answers to families' questions straight away. And they've certainly told us, anecdotally, that they found that really helpful. Another offshoot of it is that a lot of other family members can have celiac disease as well, so often a parent will have it. Sometimes it's been diagnosed in the parent because of the diagnosis in the child. So we're often talking about whole family care in clinic, and that's really useful to have everybody present for that. It's certainly helping us achieve the recommendations from BUSPGAN about care of children with celiac disease having an annual review, so we're able to make sure that that's happening for those families. Interestingly, we have lower DNA rates in our joint celiac and diabetes clinic than we do in our general one, so we hope that means we're doing something right. In the newly diagnosed patient with celiac disease, there are quite a lot of difference. Chris alluded to the fact that they don't necessarily always have better glycemic control, but one of the things we can do, and all members of the team learn from, is how to manage the changes for families when they're changing their diet, the different glycemic index of the foods that they're eating, the different types of foods that they're eating. It's really important to help them find ways to manage that. And finally, where are we going next? So one of the things that is quite helpful about these joint clinics is that it does give us opportunities for the future. One of the main ones that we're thinking about at the moment is education, using those opportunities where the families are together and they have these dual diagnoses. It's a really helpful way of keeping families up to date with things that are changing. So, for example, when the new Coeliac UK app came out, we were able to take it into clinic on the iPad, show it to families, get them to use it, and in fact they were using it together in clinic. We've certainly got a new challenge that we've had for about a month now, which some other areas in the country will have, is that there have been changes in GP prescribing. Our CCG have recently decided not to prescribe gluten-free products for people with celiac disease. So we're having to help families with that change and consider how they're going to best manage that for their individual circumstances. Some of the things we're also thinking about is because we've got these families all together, and because peer support is one of the things that has come up in a variety of places for what we should be doing next, is finding ways to help families. Recipe exchanges, thinking about gluten-free food tasting, talking about cooking tips. And also, we're starting to do the Cook and Eat programme that Maria Leveridge in Exeter has been set up in the southwest, and we're actually using that. We're going to use that as well to incorporate help about gluten-free cooking from that, as well as carb counting. So the next section is that we're going to share that. We've already shared it locally within our area. We've talked about it regionally, and our southwest group are aware of this. We're telling you now nationally. And we haven't said the word international yet, you never know. Okay. And then also, because we have a group all in one place, it means that we do have the opportunity with our group, currently 13 patients, of whether there was research opportunities within that.
We're immensely proud that we were commended for a Best Initiative award in the Quality and Care Diabetes Awards in 2015. We put this up not to demonstrate a picture of the rest of our team, but also to show that actually the reason that this was commended really was because the patient was put in the centre of this initiative. This was not about our service, our rota structure, our job plans. This was about thinking about the families, and that was at the heart of the whole thing. So our initiative didn't involve any additional costs, any additional funding or clever IT packages. We had our core members already in place. We simply just adapted what we were doing locally, and we're almost embarrassed to come up and talk to you for 25 minutes about this because it was such a simple idea. We really had to do minimal changes to our service. We feel that this could be easily replicated in any other hospital and even extended to other children who have multiple long-term conditions. We'd love to see this initiative spread throughout the Southwest and for other mighty oaks to grow nationally. Thank you very much.
Thank you very much to my neighbours. I'm Tamsin from Yeovil. I really wanted a question to Chris, and he knows I'm going to ask this one. How happy are you about that 6% prevalence, considering yours is about 10+% and mine is 13? And do you think it's underdiagnosed?
I think so. That figure was taken from the literature and is very much a pooled figure. So undoubtedly there's a range. I would say we're reasonably confident about making the diagnosis in our diabetic cohort, whereas as opposed to the general childhood population, who I think, despite our efforts to screen children with associated conditions and other symptoms, all those children with recurrent abdominal pain, chronic constipation that we should perhaps be screening, I think we do underdiagnose that population.
Holly, have you got... Yeah.
Thank you very much. I'm Martha Fleming from King's in London. We have less celiac disease there because of some of our ethnic mix, and I've really struggled to... It's very impressed, Chris, that you're a keen gastroenterologist. I've really struggled to get gastroenterology involved. I think they seem to want more hardcore stuff like ulcerative colitis, and they have got more excited in the fact that we've diagnosed some ulcerative colitis in type 1s recently, and they're much more excited. But when I keep saying I want celiac and diabetes, they look at me and say, really? It's just too ordinary. And I'm interested, when you said the trust, is in the fact that is cost neutral? Might it be cost saving? Because you've got, that's what I'm thinking, and I might be able to get them that way, in the fact you've got 2 teams in a room and you're only using 1 room and 1 lot of weighing. I'm trying to think of, you wanted to work together, but mine don't want to work with us.
We didn't want to work together. No, we didn't.
So gastroenterology-wise, I think it's understandable in the tertiary setting. I think the gastro teams are often stretched and they have a lot of inflammatory bowel disease to contend with. The guidance suggests that you could identify a single individual. It doesn't have to be a gastro specialist, but it would make sense to pool that experience in one person. Some of the cases, particularly diagnostically, are quite grey and difficult to tease out. Tertiary hospitals, I think, benefit from having general paediatricians as part of their team, and that might fit nicely into that role.
Thank you.
Tertiary hospitals have general paediatricians too, so that's really good as well. It is actually, just to make the comment though, that it's quite good to do general paediatrics and diabetes, because it does make you slightly more pluripotential, but it's also really good to have a mixture of endocrinology and diabetes too. So actually everybody working together is best, I think. It's a good way forward. Yes.
Chris, can I be provocative here?
Chris, you're having a hard time.
Come on.
After making diagnosis, do you see that your role is less and maybe dietitian could just be in that clinic rather than you? Because
almost certainly, yes.
You say it's cost neutral, but actually 2 consultants at the same time, 40-minute appointment, in 4 hours only seeing 6 patients. If I'm a hard-nosed manager, I'm going to ask you questions.
Yes.
But I'm just asking that, could a dietitian not run that clinic?
Yes,
Why do you need you?
And I think I'm involved initially diagnostically. I think with time, management will no doubt fall more to dietetic staff. And I think our service will evolve. So we're still in the early stages of this. And I think with time, I probably will become involved more with the more difficult, more complex patients, perhaps those that don't comply as well, that sort of thing. So there's definitely room for more efficiency as our clinic model moves on.
So in Norwich, our dietitians run annual scenic
I think
clinics, and as pediatricians, we look after growth, and we are pretty capable of looking at the weight, do TTG, and in a part of annual review.
I think that dietitians are very capable of managing the more straightforward patients with celiac disease.
I think the other thing to add there is actually the importance of the importance of the family voice as well. A lot of, as Chris said at the beginning, we had a lot of families that were diagnosed with type 1 and then celiac in a very quick succession for their child, and the family's wishes are to see a gastroenterologist. And I guess you have to ask that question to yourself. You don't necessarily have to tell the answer to everybody here, but if you were a parent, what would you want? Yeah, understand.
Is there... Oh, Ragnar again. Yeah, Holly.
Well, thank you very much. I might have missed this, but do you screen everyone at diagnosis, and then how often afterwards? Diagnosis of diabetes.
So we screen at diagnosis, and we monitor celiac antibodies on a yearly basis. Mm-hmm. We no longer do HLA typing at diagnosis of diabetes, in line with several publications recently suggesting that that's not helpful.
And then I can just comment on the Swedish routine, that it's usually the dietitian and the diabetologist that manages this together.
Excellent. Anybody? One last hand up. Oh wait, Holly, jog. She's doing very well, and she's getting faster as the afternoon goes on, so that's even better.
Sorry, Chris, this is another one for you, and it's. I sometimes get asked questions in clinic which I really don't know the answer to, and I'm sure we always find ourselves in that boat. But one of them I did get asked was, look, I can't resist eating gluten. If I space out my gluten consumption, will my bowel, my villi, regenerate in the meantime if I can leave it long enough between binges? So I didn't really know what to say there, so I'm pleased to ask you.
I'd suggest, so given that, I'd suggest that they would need to space out their binges for several weeks, given that, in order to get a good abnormal biopsy result, we're supposed to be on a gluten-containing diet regularly for 6 weeks. I think regular gluten 2 or 3 times a week is going to cause problems.
Yeah. Okay. Thanks.
Thank you very much. I'm going to let you've done well. You've had more questions than anybody, so well done.